Very good afternoon to all. I will be talking about iridocorneal endothelial syndrome, multiple windows in iris. Iridocorneal endothelial syndrome is a rare condition. It can be challenging for ophthalmic surgeon to manage. It is characterized by proliferative and structural abnormalities of corneal endothelium, progressive obliteration of iridocorneal angle, iris anomalies such as atrophy and polychoria. It is sporadic in presentation and it is usually unilateral. Coming to the case, 35-year male farmer hailing from Anand, Gujarat, came to OPD with the chief complaint of diminished of vision and halos in left eye since 4 months and pain in left eye since 4 months. He was apparently alright 4 months back when he noticed diminished of vision in left eye, gradual in onset, progressive in nature, associated with pain, pricking in nature, and present throughout the day. There was no aggravating and relevant factors. Patient had shown to the ophthalmologist elsewhere, underwent laser peripheral iridotomy, and was prescribed following eye drops, moxifloxacin, dexamethasone, Dorzox-T, and CMC eye drops. There was no significant past history and no significant family history. General examination and systemic examination was normal. External examination was also within normal limit. Visual acuity in right eye was 6.6 with near vision N6, and in left eye it was 6.18 with best corrected visual acuity, and near vision is N24. Slit lamp examination in right eye was within normal limit. Intraocular pressure was 14 millimeter of mercury, and fundus was also show 0.4 CDR with full dull foveal reflex. In left eye, there was a congestion and circumciliary congestion. There was a mild corneal edema. Multiple iris atrophic patches we can see in the picture. There was a peripheral iridotomy present at 11 o'clock position. Full thickness iris holes are present at 6 and 8 o'clock position. There was a pupil was oval, which is stretched superotemporally, and it shows sluggish reaction on light. AC depth was Van Herijk's grade 3. On gonioscopic finding, peripheral anterior synechiae present extend beyond the Schwalbe's line, and it is present nasally and temporally. Specular microscopy shows loss of hexagonal shape and iris cells, that is darker in appearance, and central light spot area surrounded by peripheral clear region. We had given a treatment of timolol maleate 0.5% eye drop, which is beta blocker 2 times a day, and sodium chloride 6% eye ointment at night. And we advised follow-up after 2 weeks. Then patient lost follow-up. Iridocorneal endothelial syndrome represents a spectrum of disease. These variants are linked by fundamental defects of corneal endothelium. Altered endothelial cells also secrete an abnormal basement membrane. Contraction of these basement membrane leads to iris changes, iridotrabecular synechiae, and secondary glaucoma. Visual loss is secondary to other corneal decompensation or refractory glaucoma. These shows 3 variants: Chandler syndrome, progressive iris atrophy, and Cogan-Reese syndrome. All this shows iris atrophy and variable corneal edema. Management depend on medical and surgical. Medical treatment, anti-glaucoma medications and hypertonic saline. Glaucoma surgical management include trabeculectomy with antipyretic agent and glaucoma drainage device. It is difficult to maintain long-term success as the fistula and trabecular meshwork can be obstructed with advancing abnormal corneal endothelial cells. Cornea surgical management include penetrating keratoplasty, dissect, and demec after resolution or in advanced cases of corneal edema with controlled IOP. Take-home message: it is a rare disorder characterized by structural and proliferative abnormalities of corneal endothelium, anterior chamber angle, and iris. There is no single intervention that can treat the condition for entire lifetime. Treatment of iris-related glaucoma require filtrating surgeries. Visual impairment and pain associated with corneal edema can be successfully managed with endothelial keratoplasty, and frank discussion with the patient is required about the disease process so that appropriate expectations are set. Thank you.
So what was the management in your patient?
We have given a timolol maleate eye drop 0.5% and sodium chloride.
Only the medical management?
Yes, ma'am, we had advised follow-up to the patient, but he lost follow-up. Thank you. No, we had not done. It is it is previously done elsewhere.
Just a comment. When you were telling the history, you said a brand name actually. Don't tell the brand name.
Okay.
Torzolamide plus
Yes.
Prolol you should
Yes.
tell.
Yes, sir.
Not tell the brand.
Okay, sir. Thank you.